Well, welcome everybody to the Maine Rural Healthcare Education Grand Rounds. We are very excited to welcome our guest presenter, Dr. Marc Kimball. He's a course director for the Competency-Based Apprenticeship in Primary Care for the Tufts University School of Medicine Maine track. I should point out that this Grand Round series is hosted by the MERGE Collaborative as well as the Building Maine Network. Both are statewide grant programs supported by the Department of Health and Human Services. So we're very excited to have this presentation for you today. I'll tell you a little bit about Dr. Kimball's background. He's the course director for the Competency-Based Apprenticeship in Primary Care. He received his medical training from Tufts University School of Medicine and completed his internship, residency, and chief residency in family medicine at Maine Medical Center. He also completed, I see Callie doing a little dance there. He also completed his fellowship in addiction medicine at Maine Medical Center and the VA Togus. He's a clinical assistant professor of family medicine at Tufts University School of Medicine and practices both family medicine and addiction medicine at Maine Health Primary Care Family Medicine Westbrook. So it's great to have Dr. Kimball here. And it's just a reminder, we'll keep our cameras off for the presentation until, of course, Dr. Kimball asks us to turn them back on for some activities that he has. And when his presentation is over, we'll bring all the cameras back on for the Q&A session. So with that, Dr. Kimball, I will hand it over to you.
Thanks, David. So I'm going to share my slides. There, window. And can everyone see my slides?
Looks great.
Sounds good. Perfect. So the talk I wanted to talk, I was asked to talk about how to really teach physical diagnosis in a busy clinical setting. And I expanded, I took some liberties to expand it for models for teaching medical education in a busy clinical setting. Because you really have to know a couple of fundamentals before you get to specifically physical diagnosis, which is the way I teach it the same way I teach procedures, because it works very similarly. So of course you can get CME for attending this lecture, and what you should do is text the activity code, which is 90615, to the number listed there for Maine Rural Healthcare Education Grand Rounds. And you should receive some replies. And if you have any problems, please contact David. And I hope I'm not speaking out of turn for you, David.
That's exactly right. It's also in the chat. If people didn't see that slide, it's in the chat for you.
Perfect. And then this series is accredited by all these various governing bodies. And there are 2 conflict of interest disclosures where neither one has any. So this is the general one. So none of our planners, faculty, or anyone else associated with this has conflicts of interest to disclose. And then I also have no conflicts of interest to disclose either. And you could look for your CME on the Cloud CME mobile app. I know that I do. So my COI, I have no conflicts of interest to disclose, financial or otherwise. And then getting into introductions. So I put this in because I didn't realize David was going to introduce me. So again, I'm Marc Kimball. I'm a Tufts alum. I'm a Tufts Joe Schmo Boston track alum, but I came to Maine Med because of the educational environment that was there, and being a family physician, I really was attracted to the breadth of education that I would get in my residency, and it did not disappoint. And now I'm a faculty on the Maine track, and I lead the competency-based apprenticeship in primary care, which I don't think anyone here participates in, but maybe you have in the past. It's the first real clinical experience for our students to get them learning about primary care, learning fundamentals of how to think and act and be like a doctor as they prepare for their clinical years. So our learning objectives today is, number 1, understanding the principles of adult learning theory, because that really underlies everything that we're doing in medical school. And it's certainly the way that I approach medical education, is I'm always thinking, am I doing this in accordance with adult learning theory? Number 2 is being able to implement the 1-minute preceptor tool to help with effective teaching in a clinical setting. And that's medical decision making. And I think it's a good thing to review for everyone, but then it also goes into the next thing, which is implement the BID tool for teaching procedures and physical exam skills in a clinical setting. This should be fairly informal. Please feel free to speak out if you have any questions. And as David said, I have a few activities where we could practice these skills to really get you comfortable with it. So adult learning theory versus child learning theory. Just have a discussion. What's the difference? Just hearing those things, what does the crowd think is, how do adults learn differently than children, knowing that they learn differently?
I'm not going to answer this because last night for the My Academy, I gave a lecture on adult learning theory. So it's unfair unless anybody else wants to, but I'm just going to say one thing I will offer is that it has nothing to do with age.
I would say it's usually targeted towards something that's to achieve a goal, something that you're interested in. I know for kids too, it also has to be interesting them, but it's more goal oriented for adult learning.
Yep. Perfect. Thanks, Eliza.
I would say that similarly that for adults, it needs to be like immediately applicable.
Yep. So applicable and goal oriented. I actually think that kind of covers it. Does anyone have any other thoughts before I move to the next slide and officially go over adult learning theory? All right, I'll take that as a no. So in the 1980s, this educational, I guess, philosopher or educational scholar named Malcolm Knowles first postulated the difference between andragogy, which is adult learning theory, and pedagogy, which is child learning theory. And the way I summarize it, and the way I think of it is that adult learning theory is adults learn differently, and they, to put it humorously, adults are the kid in the class who raise their hand and say, when am I ever going to use this? Right. So that it needs to be applicable to what they want to, what their life is all about. It needs to be experiential and really towards a goal. And that, if you don't do any, and they also have to be ready for it. And if you don't have any of that, you're really going to miss out on adults. And so we see this, unfortunately, a lot of times in the e-learns that we do for healthcare, we have to do it to be in accordance with governmental authorities or who knows what. But a lot of us do these things and we don't really learn from them because they're not designed for adult learning theory. So Knowles came up with 5 assumptions. Number 1, adults want self-directed learning, right? They want it to be something they're interested in. They want it to be experiential. So not just in the classroom, but also, learning how to do things through practice. Adults must be ready to learn, and they also must have internal motivation to learn. So 3 and 5 are, I think, very similar. And then they should know why this learning objective is important. They should be able to think, either have it explained to them or come to the learning session with the knowledge of, why are we learning this? And then the flip side of that is Knowles's 4 principles, which is learning objective number 1 that I want you to take is there's 4 things that you should be doing to make your teaching in accordance with adult learning theory. Number 1, involve the student in identifying what they want to learn. So this is asking them, what would you like to work on today? And I love this question because, we tell this to our preceptors, and then I don't know how many of you have actually tried it with students. The students turn out to be like deer in headlights and they go, oh, I don't know. And then they pick something and it's not necessarily what they want to learn on. So what I try to I get beyond it, I try to develop rapport with the student, make sure it's a safe learning environment. And then through that, really work with them to figure out where are they in their medical education. And we come up with a goal together, but they're involved in part of it. Number 2 is make learning experience based. So in my course, this is exactly what we're doing. We're throwing our students into busy primary care clinics so that they can have the experience to use these fundamentals and really get to be competent, student doctors when they get to their 3rd year wards. Choose high impact material, so something that really matters. And I try to hit, when I'm teaching, I try to hit the major things first, and then once they accomplish or understand those topics and can really, master them, then I go down to the nuances. And then 4 is focus education on problem solving. So this is making things case-based in medicine, having the patient in front of you. I will learn more Actually, I'll go with, in residency and family med residency, I learned how to deliver babies, and I really learned more obstetrics in residency than I did in medical school, because I was really the one in charge of helping this woman deliver her baby and making sure everything's safe. So I learned a ton by having it be focused on the patient in front of me. So those are the four things. And if you find yourself having a student and hitting your head against a wall and saying they're just not getting it, go back to this and think, am I employing these four principles? So the problem, I don't know. I only know Callie and Tom on this, and Eliza. The screens are off, so I took a list of names, but I don't have everyone. But I don't know everyone here, but I know that, probably many of us are in a very busy primary care clinic, or all of us are just very busy. And we work for a medical system that is wonderful, but is always kind of cranking things up in terms of productivity. Since COVID, the complexity of our patients has gone up, especially around their mental health. And a lot of physicians are feeling burnout. And so in that, how do we teach medical decision making in the midst of all of that mess? And so I'll invite you all to turn your cameras on if you'd like to speak, and just answer how, and I assume you're all involved in education, how do you educate despite all of the stress that we have in our jobs, and how do you make it meaningful?
Mark, I'll share. I mean, when it's really busy, try and utilize like debriefing and reflection a lot, because there's not as much time for like pre-planned teaching. So after we've had like really busy session, just asking students, what they thought of things, or did they understand what I was thinking here or there. That's probably one of my go-tos for really, really busy moments in the day.
So letting the case present itself, you see a learning objective saying, oh, you have someone who just had an acute MI, and because inpatient, right? And so like focus on some tidbits that the student can take from that experience. That's, I think, very strong. And that's part of what I'm going to teach.
Sometimes when I ask students, what would you like to learn today? And they're not able to really articulate a goal, especially because I'm a psychologist. And so sometimes they have no idea how to think about what they might want to learn from me. I'll say, well, one thing that I would like for you to learn today is, and then after having provided them some structure, I'll follow up and say, how might you relate that to some of your goals? And they're able to, with having some structure from me, they're then able to apply that a little easier than coming up with a goal themselves out of the clear blue sky.
I'm going to steal that. I love that, because then they have the deer in the headlights moment. So you've diagnosed the learner, right? So you think, what's their next step in their learning. So you offer it, they accept, and then you invite it to go back into their realm so they could have autonomy over it and feel some self-efficacy. That's great. And so specifically, what I do, or actually any more things before I move on?
I would just say if I do make a clinical decision as the preceptor, just making sure I explain how I arrived at that decision and how my thought process. Yeah. And then for the actual student or resident, it's just, simple phrases like, what do you want to do? Or what do you think is going on? I think those invite the learner to express their thoughts and decision making a little bit more.
Exactly. So in a safe and a very structured way, Tom, you're getting them to put their money down on either a diagnosis or a plan or something that, that's really the key of what I do as well. And so specifically what I use is the 1 minute preceptor, although I learned it through the family med world, called the 5 micro skills. This came out in the 1990s through it was invented through a family medicine residency. And I think it's applicable to most medical education. And I think you could probably also, apply this to psychology as well, although I want to make sure I think about that as well. but it's essentially 5 things to do after a patient encounter. So you let the patient come in, the student, if they're on their clerkship, they're seeing the patient, they're obtaining the history, doing a relevant targeted physical exam, reviewing, laboratory data, and they're presenting to you. And once they do their assessment, you get the student, number one, to put their money down on a differential, to commit to it. And I actually push them. So if I have a student who I go, what's on the differential? And they go, infectious and inflammatory, I say, you're not allowed to say those words, right? Go more, because I would rather have them be wrong and learn something than be safe and not really learn anything. And so get them to commit to something. Second, probe for their evidence. So let's say, we're going to do an example of this. Probe for evidence of why they think about that differential, and then once they have that, teach the general rules and concepts of how you think about this, and have it be a high impact learning, micro lesson. Reinforce the feedback of how the general rules apply to either support their differential or how the differential really doesn't fit it. And then, talk about how it's what they did well, and then what they could be doing better in the future. And that usually takes at most 5 minutes for me when I do it. But it's, it could be longer, it could be shorter, but that's something that I could easily fit in to my very busy clinic schedule with high needs, primary care addiction med patients who sometimes come in all sorts of extremis, and still have it be meaningful learning for them. So that brings us to our first role play, if everyone wouldn't mind putting on their cameras. And what we're going to do is, everyone here is going to be my preceptor. So you're my collective preceptor. I am the learner, and I am on my 3rd year family medicine clerkship. And I'm going to present a case to you. I'll give the subjective and objective case. And then I'm going to give my assessment and plan. And all of you feel free to do the following. Ask me to commit to a differential, probe for the evidence of why I think that's it, teach me a general concept, and then, say, what went well and what could be done in, better in the future. Is everyone comfortable with this? If not, it's all right. We're still doing it. Good. All right. So I just came back, and I'm looking at Tom, so I'm going to present to you, Tom, but that's just because you're on the screen right now. So Mrs. S is a 56-year-old woman who is, actually, no, I'm going to change it. Ms. S is a 24-year-old woman, female, here for fatigue. She has been feeling fatigue for the past 6 months. She has been noticing a little bit of dyspnea on exertion when she walks. She usually runs. She used to run marathons, and now she's having a hard time, running even just 3 miles. But she's able to get around with her ADLs. She hasn't noticed any fevers or unintentional weight loss. She is having, she's having regular periods, and she hasn't had any bleeding from her rectum or with her stool. Her social history is notable. She's a new mother. She gave birth a year ago. It was uncomplicated vaginal delivery, and she is staying at home with her kids and having a hard time keeping up with them. She doesn't use any substances. She's a never smoker, and she has a family history of rheumatoid arthritis in her grandmother, and then heart disease in her father, diagnosed at 50 years old, where he had an acute myocardial infarction. Her vital signs: she's afebrile, she's hemodynamically stable, her oxygen is 98% on room air. She looks pale, and she looks fatigued in general. Her cardiac exam is regular rate and rhythm, a little bit tacky, but not really. Heart rate at 99, with no murmurs, rubs, or gallops. And her pulmonary exam is clear to auscultation bilaterally. Abdominal exam is non-tender and non-focal, and she has no rashes. Taking it all together, this is a 24-year-old woman who has fatigue, and my differential really for this is it could be something infectious or inflammatory. And what do you think?
And Mark, this is for the group to now reply. Is that right?
For the group now replies.
Anyone, you are
my
all the
preceptor.
preceptors. Everyone here is the preceptor.
I'd ask Mark, can you be more specific as far as what you're thinking with the differential diagnosis when you think about inflammatory or infectious causes?
Yeah, so I'm worried she has RA. And that so right now that her great grandmother having rheumatoid arthritis, I mean, I'm worried that this is a presentation of that. Infectious, I mean, HIV is on there. And I mean, it could be endocarditis as well.
You describe that she has no rashes, but I don't remember you describing what her joints were like. So can you describe what you saw looking at her hands and her wrists and
very good point.
Joints?
You're
thinking rheumatoid arthritis. Where's the arthritis?
To be really honest, because I feel very safe in this learning environment, I didn't do that exam. I just I'm worried about RA.
Okay. Did she give you any history that would suggest that?
Just the family history.
Family history.
And what kind of things would you look for on physical exam or in the history that would support RA as a likely diagnosis?
So I'm trying to remember back to second year. I'm just, this is my first rotation, and I think I would look for signs of arthritis and look for pain. That'd be the biggest thing. Come to think of it, she is mentioning that her periods are getting a little bit heavier, and like maybe she has like a bleeding diathesis. So like I don't know, maybe this is like it's like a not factor V, but like some sort of hereditary bleeding problem, hemophilia. So I know you've told me to put my money down on stuff before. If I'm going to put it down, I think this is RA. And what I want to do is get a rheumatoid factor, a CCP, and an ANA, because I just can't ignore that family history. And there's no way that I want to miss this. But I'm here to learn. Could you teach me a general concept about how, how you would approach this, or, this patient, or what you think is going on?
Do you have an approximate idea of what the patient's going to pay for those lab tests?
I just assume it's covered. How much? What do you think it's going to cost? I didn't even think of that.
Well, you could certainly, here's the resources we can direct you to. You can find out what the fiscal note of that would be. But
so I think you're trying to teach me that cost might be something to think about in healthcare. I didn't think about that.
Yeah.
Well, I guess, with this patient, what, maybe I'm wrong about this. What do you think is going on?
probably where I'm not sure where you're going with this, Mark, but and I'm not an internal medicine person, but I'm thinking premature closure on a diagnosis. It just, and so I probably would ask more about your I would refocus you on your differential. And if this is in fact not rheumatoid arthritis, or I don't agree with you, then I would take the, sometimes we can overemphasize one part of the history, and that really leads us down a path of sort of premature closure on a diagnosis. Pull back and then, consider all of the other diagnoses. So I'm not sure if that's helpful in this particular case.
So this is perfect time to call the scene. So that's exactly what I was doing, is premature closure. And I'm glad you were talking, Callie, because she was just having some menorrhagia, which was causing her to have anemia. And so that's it, but it felt kind of uncomfortable, right? Because you have a student who they just learned all this stuff for step one, and they automatically go to the like really they get premature closure on their thing, on their differential. And it's important to teach them to expand it, and then maybe think about, all right, well, how do you work up fatigue in a 24-year-old? So hopefully that was helpful. Maybe when I give this talk next time, I'm going to try to do a better case that's maybe more clear cut. But that's really what I was trying to teach, is to be able to do those 5 things. So going through it, I gave a broad differential, and you asked me to commit to something, and so I committed to it. Probing for evidence, I really had very little evidence, and so as a learner, that showed me, oh man, I'm kind of getting over my head. Teaching the general concept of, number one, thinking about cost in healthcare, and then also thinking about premature closure. And that's part of the reinforcing feedback and really the corrective feedback in a safe learning environment. All right, so then cameras back off, because we're going to go on to the next subject, which is part 2. And this is the original topic of this, which is, how do you teach physical exam skills as well as procedures in a busy clinic? So, for my course, I have busy primary care docs who are cranking out AWVs, trying to deal with, healthcare HCC codes and whatnot, as well as deal with the increasing anxiety of their patients and the increasing medical complexity. And I'm asking them to go over the fundamentals of physical exam skills with my students. So have any of you experienced this? And if so, how do you do it? Maybe try to get some best practices.
I think always asking the learner, what portions of the physical exam they're looking to get better at, so whether it be musculoskeletal or neurologic exam. So you can begin to focus it a little bit on what they're looking to improve on.
Perfect. So briefing beforehand, obtaining a targeted learning objective for a certain encounter. What else? What else is helpful? And it's all right if that's it. Because I think this is why I was asked to do this talk, because a lot of times people have a hard time doing it. And one thing we have in my course that's been a problem is a lot of times we just have the students, the preceptor only feels comfortable having the student shadow, and then that causes the student to not feel that great about it. And we try to have them get beyond it. So my learning objective number 3 is to teach you the BID model, which comes from the surgical literature. And it came from answering the question of, how do we teach our residents in surgery, and I think also obstetrics, to be better surgeons, to be better, to do better procedures in an effective way. And so they created this model where it's briefing the learner before the procedures, identifying a reasonable goal, just like Tom said, providing intra-procedural teaching and not shying away from that. You want to make sure it's safe, and both for the patient, but also for the learner. It's a safe learning environment, but being able to provide corrective feedback in the moment, and then afterwards debriefing after the procedure has been done, or the physical exam has been done, and talking about what went well, what didn't go well, and how would they move up, and moving up this thing called the Swish scale, which is, it's essentially teach one, or show one, do one, teach one, but it's showing, needing active help during the procedure, needing passive help during the procedure, and then supervision only. So for another role play, hopefully this goes better. I'm the learner, you're all my preceptor, and we've all been going to weddings a lot, and I'm trying to do this thing called the Macarena, and I just can't do it. And so just, if everyone has cameras on, do people, my wife told me that I'm dating myself with this. Do people know what the Macarena is?
I do remember it.
Okay, sounds good.
Do you know the Macarena?
All right, so I will show you how to correctly do it, but I keep leaving out a certain step, which makes me out of sync, and then I bump into people, and that's it. So for purposes, so this is, because I was going to have a graphic on how to do Macarena, but all of it didn't really seem very, it was like scantily clad people, and I didn't really feel comfortable on this. So I'm just show you how to do it. So it's hey Macarena. All right. Sound good? All right. So we're about to go to a wedding. And I really want to work on my Macarena with you, Tom. What did I do wrong last time, and what can we work on?
Oh boy, I don't know if I know that dance that well to tell you what you might have missed.
You were telling me that I was leaving out a step, that I was leaving out crossing my arms.
Mark,
maybe I should work on.
We couldn't really see your hands very well. If you show us again the way you're doing the Macarena, yeah, maybe or scoot back a little bit.
All right, there we go. There we go. Can you see me now?
We can see, yeah, we can mostly see when you, like your shoulders, we can see. So as long as it's in front of your shoulders,
all
we're
right,
in pretty
there
good
we go.
shape.
Yeah, so I think, Tom, you were telling me at the last, you were like, Kimball, you're not crossing your arms, and that puts you out of sync. I think let's work on that. I want to work on crossing my arms. All right, so now we're at the wedding. We're doing the Macarena, and I want you to tell me, what am I doing wrong? So here we go. Bump, 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 I'm off. Here, let me try it again. Oh, what am I doing wrong?
Well, I'll jump in as a preceptor for you here, Mark.
Yeah, David, let's
Mark,
go.
I was just noticing that you put your hands out correctly, and you did the hand flip the right way, but you went right to your head.
That's right. I missed crossing my
we've
arms.
studied this. You need to
right.
cross your arms first, right?
There we go. All right, so let me try it again. Oh, there we go, David. That's it. All right, and now we had the wedding, and I didn't bump into people, and I had a better time. All right, so I hope that was fun. But think about this. So when we're teaching physical exam skills, so I had a patient who had acute onset shortness of breath, history of COPD, but he felt this was different. And I was seeing the patient with a student, and I was percussing the lung fields, and he had dullness to percussion to the sixth rib on the right. And I was trying to teach the student, because it seemed that the patient clinically had a pleural effusion. We wound up getting an X-ray and confirming it. But the patient, or the student, really couldn't get the method down for percussion. They were doing it wrong. They couldn't get that whack to really get it to resonate. And so I used this model where, with our next patient who didn't have this feeling, I was having them percuss the abdomen, because you could usually get some resonance there, and really teaching them how to flick their wrist and hit the hand to get a better sound. They wound up doing it. So I found this model to be very helpful, and in terms of teaching physical exam skills, or even teaching procedures like a derm procedure, or if you're in the operating room like a C-section, this is a good way to make sure you're moving the student up that Swish scale every single time. So without further ado, we're at the end, right? So we talked about the principles of adult learning theory, making sure everything is case-based as possible, applicable, and the student is motivated, and this is important. Using the 1-minute preceptor, so getting the student to commit to a differential, and then probing for evidence, and then using the BID tool for teaching physical exam skills as well as procedures in a busy clinical setting. And so thank you all for your attention, and hopefully I think we have enough time for a discussion about how this, what you think, and any other questions.
We certainly have time, and I invite everyone to turn your cameras back on. And thank you, Dr. Kimball, for all of that. And please, I do open the floor to questions from anyone in the group. Thoughts, comments, and reactions. First time we've done the Macarena in our Grand Round series.
That was good. I will stop sharing so I could see everybody.
And I see Callie has her hand up.
This is thank you for sharing the BID method. It's actually, it seems ridiculous, but we use the BID method a lot in surgical procedures. And so the idea that can be transferred to an out of the operating room procedure, you would think that would have been an easy from here to there for me. But I do think that the BID method is incredibly helpful. One of my experience in using it is that sometimes adult learners need a little bit of mentorship or coaching about what it is they want to work with. And so when you've got this long-term continuity, they may want to work on say, for example, in the C-section, they may want to work on speed to get from skin to baby. And as preceptor, you might be like, this is not an emergency. Why don't you take it more slowly and focus on the fascia or whatever? I do think that there's some negotiating that can happen with them before the procedure.
Exactly. And actually, just to take it another step. So, I don't know if he knew he was doing this. He probably did, but Bob Sansonetti really taught me how to do the cervical exam, right? And he was using this method with me where I was talking about, like, I didn't know what I was doing with that. And he said, all right, well, what are you doing? Show me with your hands what you're doing. And he was able to identify some tips that I wound up using. And that's how I teach the cervical exam. And so he used that method. It's very, very helpful.
He would be so happy to know that.
Great.
That's fantastic. He's retired, but if I bump into him, I'll let him know, Mark.
Yep. I can't emphasize enough how much this is very helpful for physical exam skills, especially the subtle things like percussion, or actually the big one is JVD. So our students they're supposed to know how to do JVD, but they don't. And so for those of you who don't know, jugular venous distension. So it's a sign of heart failure, a clinical sign of heart failure where someone has fluid backing up, and we could see it in their neck. But they don't really, they don't get the practice on it because they haven't seen people with that sign yet, right? And so, and that's the problem, is that in primary care we do see it, but it's more often that we're seeing healthy people. So I use this all the time to go over, all right, how to put the patient in the right position, how to measure it, and doing that procedure, which is actually just the physical exam.
I think having like a pre-meeting with the learner at the beginning of the day, or even the day before, looking at the list of patients that will be coming in and really kind of coming up with an educational plan for them of, if they're looking to work on a specific physical exam element, which patients may line up with that, if somebody's coming in with a specific complaint. And sometimes it might be you, or it might be one of your partners have somebody on their list. So I think just the more that you can plan will really help.
Yep, that makes sense to me. And I saw something in the chat. Hold on a second. Let's see.
Just really recommending
thank
this
you,
as a
Ann.
conversation point.
Yeah, good.
All
right,
Mark.
Yeah.
Mark,
go ahead,
one
David.
observation I've just had in all of this, and I'm probably the one person without medical training at all, but I do have a lot of years in education. And what I love that you've mapped out here is something that works for children and adults. And it's some really simple concepts of when you're going to teach something, first, you need to tell someone what you're going to teach. Then you teach it, and then you tell them what they just learned, right? And that can happen in 1 minute. It can happen in 30 minutes. And there's different programs that are appropriate for that. But you've really mapped out a plan for how you get them invested in what they're going to learn. There's going to be a teaching experience, and then there's a reflection. And you've done different strategies for that. And that's not limited to medicine. That's really how we all take in information in that set of three.
Exactly. And, medicine, we deal with very complex subjects, but the learning process is still the same, right? And if we're able to break it down into little bits for the student to master, then they'll get there faster than them trying to, bang their head against the wall and pretend their way through it.
Well, folks, I want to make sure there's plenty of room for anyone else that has thoughts or questions on this presentation before I do my official wrap up. Frank?
Yeah, I really appreciate your presentation on the 1 minute preceptor. I've shared this with many preceptors, and the way that you kind of carried the interaction through and really committed to that was phenomenal. I think a point that cannot be understated is setting those expectations at the forefront, like you did, sets up that safe and supportive learning environment. Sharing that, I was just at a conference yesterday talking to several students, and one of the things they says they often feel in the way, that they show up and the preceptor has already set their mind to, okay, let's go. You're the med student, I'm the preceptor, let's do this. Great. And so oftentimes being so busy, there's that kind of lapse in that introduction and managing and setting those expectations that's missed, and the med students are reticent to really step out there. They don't want to step on anyone's toes, but that's a really important part of the process. And I appreciate that you did that and did it well. Kudos.
Perfect. And that's it's not only are they not in the way, but sometimes they're actually, or many times they're actually very helpful. So I had a student with me in my family med, I teach for family med clerkship last month. And in her presentation on this patient, not to give too much info, she said, as an aside, this patient's not on long-acting reversible contraception. And I engaged her, and she committed. She's like, I would like to talk to her about getting a Mirena. And I went, could have had a VA. Yeah, absolutely, great idea. And so we had a better patient outcome because the student felt confident and had self-efficacy to be able to be wrong, to be able to put something down. And now we have, better patient care. So that's the benefit.
Outstanding. Well, folks, we're coming up on time. I want to thank everyone for joining us. Thank you, Dr. Kimball, for that presentation. And I'd like to just briefly share that next month we'll have the last of the 2024 series of our Grand Rounds. It's going to actually be presented by our DEI specialist, Tanya, for the Merge Collaborative. And she'll be giving a presentation called Rupture and Repair DEI Accountability Measures in Practice. So really, this is not just a general DEI presentation. It's going to be about in the how we can really support our learners in a DEI context. So really excited for that one. It's going to be the same time, same place, the second Friday of next month. You'll get lots of updates as we go along. So I hope to see you all there. And if anyone ever has questions, you know how to find me. And I look forward to it. Bye, everybody.
Bye.
And again, Mark, thank you so much. Great presentation. Really appreciate your time.
Thanks for all your help. Bye.
Have a good one.
You too.